Well, hello and welcome to another Saturday live session by Team Gyan. Today, we are going to have an interesting session about some interesting breast cases. Before we start on today's session, some housekeeping, which I have some housekeeping to do. Number one is my friend and your host, Dr. Amar Udare, has started this platform for education purposes. He's a radiologist who is passionate about teaching. We help him out with his endeavors. So all the content which will be discussed in today's sessions, all the previous sessions, as well as the upcoming sessions will be for educational purposes only. This is not a medical advice. If you have any questions about the presentations that we do, the work which is being done on this platform, as well as the website, please feel free to reach out to us with your questions, and we'll be happy to answer. So remember, before we jump into the session, always remember to revise your BI-RADS assessment categories, because this is something which you are going to give in your reports. When you assess any case with any breast symptoms, or even if you're doing it for screening purposes, make sure that you're using the right BI-RADS terminologies. So again, I will not spend a lot of time here. You can find all this information on American College of Radiology website. There will be categories such as 0, 1, 2, 3, 4A, 4B, 4C, 5, and 6, depending on your level of suspicion for malignancy or whether you feel that the lesion is benign. So you can find all of this information on ACR website. It is these cards are easily available to download. Always make sure that you are referring to those cards before you proceed to giving any assessment categories. So again, for those of you were on the quiz, I'm so sorry for the technical issues which we had with the quiz, but we are going to attempt these questions right here in the presentation. So this was the first case which we discussed on or showed on that quiz. So pay attention, there is just a single ultrasound image. There's a woman in her late 30s who is presenting with a palpable lump. Look at this image and try to assign BI-RADS categories. So for some of you who were on the quiz had already answered this question, and they had given the assessment category as 3. For those of you are new, again, you have to make sure that you look at these lesions completely, make sure that the assessment is complete. And the most important thing is that try to start doing annotations of the image if you're not. So at least annotate whether it is right breast, left breast, are you in the axilla, what O-clock position you are in the breast, how many centimeters from the nipple is the lesion located. Try to take at least 2 pictures of the lesion in orthogonal planes. And that's basically how you can complete the annotations of the image. So I can see that all of you have answered as BI-RADS 3, which is the exact choice which should be picked up in this case. So let's see what happens with BI-RADS 3 category. So what happens with BI-RADS 3 is that they still have a very low suspicion of malignancy. It's usually below 2%. And that's the reason why you have to follow them up for serial imaging tests. It's usually you start with a baseline, do the first follow-up in 6 months with ultrasound. If it was seen on ultrasound, then do another follow-up at the 12-month point, and then another at 24 months. So you show that in the period of 24 months, which is 2 years, the lesion has not substantially changed, then you can downgrade that lesion to BI-RADS through. So in this case, what happens was that the patient was left on follow-up, and after 6 months, we did repeat an ultrasound. On the repeat ultrasound, it definitely appears that the size of the lesion increased to 3.5 by 2 by 3.5 centimeters. In a nutshell, you have to look at 2 things when you're doing these follow-ups. Number one is whether the size has increased by at least 20%, or if the margins have changed. So now if the margins start to show some angulations, microlobulated margins, or do they have some angular or spiculated features? Because those are the cases where you have to bump up these BI-RADS 3 into BI-RADS 4 or 5 and perform an image-guided biopsy. So in this case, the lesion enlarged in 6 months, so we decided to go ahead and biopsy, and the final diagnosis in this case turned out to be invasive ductal carcinoma, no spatial type, which was ERPR positive and HER2 negative. So this is the exact reason why we have BI-RADS 3 categories. Sometimes early cancers can appear quite circumscribed. So first important thing to do is always make sure that you assess margins completely. Make sure that you look at all the features of the lesion before assigning it a BI-RADS 3 category. But even if you're assigning BI-RADS 3 category, it is going to have a less than 2% risk of malignancy. It is not going to always be benign. You will always catch some cancers on follow-up. And that's the whole point of doing these BI-RADS 3 follow-up imagings. May it be on ultrasound, may it be on mammogram, or may it be on MRI. So now what happens is that In this case, the lesion appeared more or less similar features in terms of margins, but the size has enlarged. But in case you do have enlarging lesion or change in morphology of the lesion, you can always add a mammogram to confirm or complete your assessment. Always make sure to use all the imaging modalities which you have at your disposal before assigning a BI RADS category to that patient, because that is going to assign a management option in case it turns out to be a cancer. So I see a comment on YouTube which is no, so I'm not sure if that was for the older part of the video feed. Make sure that you refresh your YouTube video feed to see it live. Sometimes there's a bit of a delay in terms of what is being transmitted on YouTube. So if you can refresh, you will see where we are right now. Okay, so some teaching points about this case. So as we discussed, BI RADS 3 category lesions have less than 2% likelihood of malignancy. The likelihood increases as you go through categories 4, 5, and obviously 6 is known cancer. Make sure that you are not using it if you are unsure of the findings or with incomplete assessment. Sometimes the margin is not completely assessed because of various factors. It can be a limited scan. The patient may not be cooperative, or if the patient has some other physical limitations for you to preclude complete assessment. So make sure that you're not using this category in an incomplete assessment. So what is the expectation here? The reason to use BI RADS 3 category is to reduce false positive biopsies and to increase cancer detection rate. That is why this category was designed in first place. Avoid its use again in patients who have new breast cancer diagnosis, because there is always a less than 2% chance of malignancy in these lesions. You do not want to leave an undiagnosed cancer in a patient who already has another primary malignancy in either the same breast or contralateral breast. So you may have to biopsy those lesions at that time. If patients are on organ transplantation wait list, it is recommended that they should not have these BI RADS 3 lesions, because that can change the patient's outcome significantly. If the patient is pregnant or planning a pregnancy, if you're not sure of the findings, always you can go ahead and biopsy, because as you're aware, with pregnancy associated breast cancer, PABCs, they behave quite substantially different from all the other breast cancers. They can grow very rapidly. Let's go to the next case here. So this was where we stopped our quiz, but let's try to answer the question here. So a woman in her late 60s presents with a left breast palpable lump. So now I have given you 2 ultrasound images. So again, pay attention to the annotation. I have given you the breast, which is the breast involved. I have given you the O-clock position in the breast, how much distance from the nipple, and I have given you 2 pictures. One is radial and anti-radial. So what are these things? So imagine you're doing an ultrasound of the breast. As you start to go ahead from the nipple towards the periphery of the breast, that will be your radial plane of scanning. So if the transduction is parallel to that plane, it is radial. And when you turn orthogonal to that plane, it is anti-radial. So that is how you should assess margins of the lesion, both in radial as well as anti-radial plane, to complete the entire assessment. So Amal, Minu, and Selda all have answered as BI RADS 4. And that's exactly what we are looking for in this case. So what is our job? If we see this, this breast mass when the patient comes in with a palpable lump, always make sure that you at least add a mammogram if it is available at your facility. What will you see on mammogram? That perfectly seen on this lesion here. This is the MLOV of the left breast and CCV of the same left breast. You see this irregular mass, and the mass definitely has these speculations going to the anterior aspect, and some of the margins are definitely indistinct, and the same is happening on the breast ultrasound as well. We are going to come back to discussing some of the lexicon terminologies of the breast lumps or breast masses on some of the later slides. So Wakar Azim is asking radial and anti-radial. So again, just to be clear about that finding, so radial and anti-radial are nothing but 2 orthogonal planes to one another. If your transducer footprint is parallel to the radial plane of scanning, that is radial, and if it is perpendicular, that it is anti-radial. So when you're looking at breast masses at, say, 3 o'clock position, you start from the nipple, start going out, you will see the mass turn it on an orthogonal plane, you will see it in anti-radial fashion. It is just to make sure that you are completing a margin assessment on ultrasound. On Doppler, you see a little bit of vascularity as well, but as rightly pointed out, we biopsied it, and it turned out to be an invasive ductal carcinoma, no special subtype. It was ER positive, but PR and HER2 negative. So teaching point here is that use mammogram wherever appropriate to complete your assessment. It does not matter if this was a breast ultrasound finding. If you feel that the lesion is suspicious, you can always add a mammogram at your discretion. There is no contraindication to adding mammogram as such, as the radiation dose is very, very low. So there is an important point to discuss with respect to this slide, which is what are these appropriate imaging tests when a patient comes to you with breast symptoms. So all like this entire slide is designed based on the guidelines from NCCN. So if you don't know what is NCCN, National Comprehensive Cancer Network has these amazing guidelines on various problems in the entire body. They have guidelines for breast, pancreas, liver, everything. So this is the version 1 2020, and this was accessed on April 2021. So you have to divide your patients in two groups, less than or equal to 30 or more than 30 years of age. Depending on that, you can start with one imaging test depending on what is available. So ideally, more than 30, you're going to start with a diagnostic mammogram first and then add ultrasound to complete the assessment. Because remember, between the ages of 30 to almost 50 years, many of the women can have quite dense breasts on mammogram. So you may not see breast cancers all the time. You may miss them if the breasts are heterogeneously dense or extremely dense. Less than 30, the appropriate imaging to start is a diagnostic ultrasound. Then once you complete this, you have to give an assessment category as whether it is BI-RADS 1 and 2. If that's the case, the patient can return to clinical follow-up. If the category is either BI-RADS 3, you have to do appropriate imaging follow-up, whether ultrasound or mammogram, depending on which abnormality picks up the finding. And if it is BI-RADS 4 or 5, you have to complete assessment with a biopsy. So this is just the algorithm. You can probably take a quick screenshot of this, this slide, or you can access the guidelines on NCCN anytime. All the trainees out there, you can get a free account or free login to NCCN. All you have is just to register, and you can access all these guidelines. So let's look at the next case, which is the third case. A woman in her 30s presents with a palpable lump and it is enlarged from previous size of 2.3 by 2 by 1 centimeter. So the current size is given on this image, which is 3.6 by 3.6 by 2.1 centimeter. So again, look at the annotations. I'm annotating it as left breast, 3 o'clock position, 4 centimeter from the nipple. So please go ahead and assign your categories, whether it is 2, 3, 4, or 0. So I see Selda, Amal, sorry if I'm pronouncing it wrong, all of you are answering as category 4, which is a very good choice in this case, and that is exactly what we did. And the reason for that is basically you don't see distinct margins on some of these images. But remember that at the edge of the lesion, there is going to be edge enhancement artifact. So some of the times you will not appreciate those margins well, but in any case, you definitely see that some of these margins are indistinct, and that is why it was biopsied. So again, there is an important piece of information which I withheld from you, and that information is that this patient was pregnant at the time of this assessment and in her 3rd trimester. This was a previous ultrasound, and this is how the palpable lump looked like. So again, the lump has enlarged in size and changed its margin, and that is why it was biopsied. But ultimately, the final diagnosis in this case turned out to be a lactating adenoma. So now, this is one of the imaging pitfalls which we have to come across when we are assessing these patients, especially the ones who are in their 3rd trimester or in the early lactational phase. They may have lactating adenomas, and what they are is that you can appreciate it on imaging. You see all these echogenic portions in that lesion. It is a very hypervascular appearing lesion on ultrasound, and they may be present in places where you had previous fibroadenomas, or they can appear de novo. But the biggest imaging pitfall for these lesions is that they can also have microlobulated margins, which is one of the categories which puts it into the BI-RADS 4 assessment category. So nonetheless, we have to apply our BI-RADS tool or look at these cases with our BI-RADS lens and make sure that we make appropriate recommendation. So coming back to shape and margins, this is something which we always have to keep in mind when we are discussing these breast masses on ultrasound or mammography. So let's discuss about ultrasound features or ultrasound descriptors for now. All you have to look for is start with shape first. Is it round, oval, or irregular? Then is it arranged parallel to the wall or not parallel to the wall? And what is the margin like? Is it circumscribed? Circumscribed means that you can basically move a thin pencil all around that lesion and make sure that the lesion is circumscribed. If at any time, if you feel that the lesion does not have a sharp interface with the surrounding breast parenchyma, that is when you lose the descriptor of circumscribed, and you have to think of other options which are indistinct, angular, microlobulated, or spiculated. So this is a typical example of an oval, parallel, and circumscribed mass. Let's look at another example here. So again, this lesion is not round or oval because you're not able to appreciate the margins that nicely here. This is an irregular mass. This is arranged not parallel because the anterior-posterior distance is larger than the transverse. And this definitely has indistinct margins. You don't know where the lesion ends and the normal tissue begins. So there is indistinct margin for this lesion. This turned out to be an invasive ductal carcinoma. Then another example of a typical cancer, how it appears on ultrasound. So this is an irregular mass, and it is arranged not parallel or anti-parallel, and it has spiculated margins. So again, another example of a spiculated tubular carcinoma, which is one of the subtypes of invasive malignancies. Okay, so now let's jump to one more case here. This is a very interesting case, or some interesting finding to always keep in your mind. So we have a woman in her 50s who is presenting with a palpable lump. She was followed for 6 months, so she was recommended a BI RADS 3 follow-up. So look at this image. It is at 9 o'clock position, 3 centimeters from the nipple. Go ahead and assign a BI RADS category to this finding. Do you think that it is BI RADS 3, 4, 2, or 0? What category you feel fits the best with this category? So I can see some options. Aisha has given as 4. Amal is telling that it's 4. Zelda is telling it's as 4. Yeah, so most of you are going in the direction of 4, which is probably a good choice as well. But let's see, Mark is also suggesting that it's a category 4. Then we have Anupam who is saying that it's 4. So all of you are suggesting that it's category 4, and we should go ahead and biopsy it. So let's talk about what happened in this case and then what we need to do to make sure that we avoid that pitfall. So she was recommended a follow-up of 6 months. So it was quite certain that some of these lesions appear to have what looks like some dilated cystic spaces. So one of the most common entities which has this appearance is nothing but fibrocystic change. So fibrocystic change is a abnormality which occurs at the level of TDLU. You start to get ballooning of TDLUs, which are terminal duct lobular units, and they are filled with fluid secretions. In pregnant women, they are filled with milk, and they appear quite anechoic and tubular or bunch of grape-like appearing cystic spaces on ultrasound. So probably that was something which was thought at that time when the baseline assessment was performed. So it was decided to assign a category 3 and do a follow-up. But unfortunately for the patient, in 6 months, when we repeated the scan, we looked at the same area, and then it was realized that essentially the mammography was not completed at that time, right? So that is something which you have to add, especially in a patient who is in her 50s coming with a new palpable lump. So let's look at the mammogram and let's see what it turns out to be. So we did assess with mammograms. So again, all you see here on the right side, on the left side of the screen are your right MLO view, left MLO view, right CC view, and the left CC view. So the first and most important thing which strikes you is that I'm not sure if you're appreciating the same on your screens, but look at the change in the contrast or the brightness of the breasts. Compare it from the right side to the left side. So on right side, the breast appears quite dark, especially the fat appears quite dark as compared to the left side. And you definitely see this focal asymmetry in the upper outer quadrant of the right breast. And that is nothing but the area of patient's palpable concern. So you have focal asymmetry, and this appearance here where you're seeing that one breast is darker than the other. Always start thinking in your head, why is one breast appearing darker than the other? This happens with all the new mammography machines where they are doing automated exposure control. So they will try to create an image with a similar contrast for you by adjusting the exposure of the image. So for breasts which have a large carcinoma hiding within that dense glandular tissue, you are going to see that it is trying to absorb a lot of photons. So the breast is going to need more radiation to provide you with same appearance as that of the contralateral side. So what happens is that if the exposure is large or higher, the fat is going to appear darker as compared to the other side. And that's exactly what is happening. So when you see this, make sure that you go turn on all the image overlays and look at the exposure factors, check the KVP and check the MAS to confirm your hypothesis. And once that is confirmed, you are thinking of something hiding underneath there. So CELDA has given an answer of ILC, and CELDA, that is an excellent choice. That is exactly how you should approach these kind of mammograms. So nonetheless, we saw this and we were like, we have to assess this patient further. So one of the new and emerging techniques which has been used widely is contrast enhanced spectral mammography. So what it does is that if you can imagine a dual energy technique which is used in CT scans, it is almost similar to that. You acquire one image, which is your low energy image, which is nothing but your mammograms, and then you give intravenous iodinated contrast and acquire high energy views, and then subtract that the baseline low energy views from the high energy views, which will create the area of iodine uptake. So you definitely see that there is this large area of enhancement in the upper outer quadrant of the right breast, which was corresponding to the focal asymmetry on mammogram, as well as you saw on ultrasound that there were some few cystic appearing areas, but you definitely did not see a mass there. So going back, how it is going to appear like on some of the images is like these cystic spaces. That is what misled to assigning this patient as a category 3. But nonetheless, start with your clinical assessment. Make sure that you're offering appropriate imaging tests before offering your BI RADS category. So look at what happens on 6-month follow-up to the same area, just 2 pictures, 2 more pictures. Now you definitely start to see all of this vague area of shadowing, which can also be called as distortion on ultrasound. And that's the reason why they decided to jump in to complete the assessment. This is the corresponding axial breast MRI examination. Again, what you see is a large area of clumped non-mass enhancement. Again, we were not able to see any typical or specific appearance of a mass. There was extensive biopsy in this region, and ultimately on lumpectomy, finally on mastectomy, it turned out to be invasive papillary carcinoma with extensive DCIS. So the teaching point in this case, or the take-home point, will be avoid the pitfall of using BI RADS 3 for non-circumscribed breast masses on ultrasound, because the risk of malignancy based on all the provided literature is for circumscribed lesions in breast ultrasound as well as mammogram. So when you are assigning BI RADS 3 for lesions which are not circumscribed and they are not typical oval circumscribed masses or single circumscribed round mass, you are actually not sure what is the likelihood of malignancy, because the likelihood of malignancy depends on the image morphology. And literature supports its use in circumscribed breast masses where there is a likelihood of malignancy of less than 2%. And in this instance, it turned out to be more, because you have to make sure that you're applying BI RADS 3 correctly. So sorry about that annotation there. So let's talk a little bit about category 3 lesions. So category 3 lesions on ultrasound are typically non-palpable, circumscribed oval or round masses, and usually they turn out to be fibroadenomas and complicated cysts. But as we are aware that less than 2% of these can turn out to be invasive malignancies, or any other lesion with atypia, to be sure, not only invasive, but any lesion with atypia. Just switching gears a little bit and talking about category 3 on MRI, as some of you might be performing breast MRs in your center. So there is a higher yield of cancers amongst BI RADS 3 lesions. So this is just based on literature. So that's why, like, you have to keep it in mind that category 3 on ultrasound and category 3 on MR, both of them have slightly different meaning to it in terms of the likelihood of malignancy. Some of the literature supports that it could be up to 4.3% versus less than 2% on ultrasound. That's why you have to treat it diligently before assigning BI RADS 3. So what lesions can be called as BI RADS 3 on MR? You can call masses, foci, or sometimes even non-mass enhancement if it is not suspicious enough. You can assign those as category 3 lesions. And this is the reason why the risk of malignancy is usually higher, because this is a wide category of imaging findings. It's not just circumscribed mass as you see on ultrasound. Okay, so now we are at our last but very important case. this has a very important teaching point. So a woman in her late 60s, she presented with a palpable left axillary lump. So now, obviously, you look at the axilla, you do your ultrasound, and then look at this imaging test and assign what BI RADS category you want to give. Is it 2, 3, 4, or 0? So go ahead and type in your answers in the comment section, what category you feel that you should assign this lesion as. Again, remember, this is the left axillary ultrasound. So it is in the axilla, not in the breast. So I see some answers here. Anupam and Marwa, as well as Amal, are going for 4, and Selda is going for 0. So this is a very important topic to discuss here. So again, BI RADS categories are for breast imaging findings. For axilla, there is technically no BI RADS category. So most of the times we will just give it as, we will not give a BI RADS category. But if you have to, then I completely agree with Selda as well as Dilip Chand that it has to be a category 0, because the patient is coming with new palpable left axillary lymphadenopathy. As a radiologist, it is your job to make sure if the patient has a breast cancer, which is not clinically palpable to the patient. So if at all in your head, you can consider it as a BI RADS 0, because you have to do diagnostic mammograms for this patient. So in terms of diagnostic mammograms, again, you start with breast CC and MLO views. So for those of you who have not have a lot of exposure to breast, make sure that the technique is perfect. You have to make sure that the tissue covered is appropriate, because sometimes between positioning for CC and MLO, a lot of tissue can be left behind, and that means that you're missing out on breast cancers. So all you see in the left breast definitely is all these large lymph nodes in the axilla, and there is a circumscribed oval mass in the upper outer quadrant of the left breast. This was something which was assessed, turned out to be just a fibroadenoma. But anyways, this was the most concerning finding. So on mammogram, you definitely don't see any obvious evidence of cancers. You complete assessment of all the areas, you compress out this asymmetry, look at the circumscribed mass, and finish the assessment saying that, okay, there's no evidence of breast malignancy. So let's go ahead and do biopsy of the axillary lymphadenopathy. So what are the features which makes you go ahead and biopsy a lymph node in the axilla? Number 1, look for the cortex. So if you remember, a lymph node is a reniform structure. It has the shape of a kidney. Usually the long axis to short axis ratio of lymph nodes is around 2:1. The long axis is always going to be longer than the short axis. And what they do is that they drain all the lymphatics, which essentially accumulates in the cortex and then goes through the medulla and goes into lymphatic circulation again. So all the tumor cells, if they're coming towards a lymph node, which is in the drainage pathway, they will first get deposited in the cortex. So you will see abnormalities of the cortex. That is what you should be appreciating. There will be excessive cortical thickening, as in this case. There may be complete replacement of the fatty hilum. In this case, you do not see any echogenic fatty hilum. Usually you will see an echogenic fatty hilum in this portion of the lymph node. In this case, it is completely gone. Sometimes the abnormalities are not obvious as this. All you see is a focal area with a tiny bump to the lymph node cortex. That is something which also should prompt your what I can say, assessment, especially in cases where there is a known breast primary. In this case, we are still not aware, but the lymph node is suspicious. Something which you should remember, recently, because of COVID-19 outbreak throughout the entire world, we are still dealing with a pandemic, but you must be aware of this finding that patients who have recently received COVID-19 vaccination, you may get ipsilateral axillary adenopathy up to 6 to 8 weeks after completing the vaccination. That lymphadenopathy may be incidental. You may discover it at the time of screening mammogram, or the patient may be symptomatic and have a palpable unilateral adenopathy. So you may have to ask the patients whether the patient has had a recent COVID-19 vaccination. If that's the case, and the palpable, if there is unilateral palpable lymphadenopathy on the site of vaccination, you have to do a follow-up within 6 to 8 weeks, after 6 to 8 weeks of completion of vaccination, to make sure that the lymphadenopathy goes away. In terms of talking to the patients, you can always talk to them and reassure them that it is fairly common for our body to react to these vaccines, which means that the body is trying to build up immunity against this virus, and that's why it is creating these lymph nodes, but they need to go away after 6 to 8 weeks. So coming back to this case, there was no history of COVID-19 vaccination, and this was a completely new unilateral palpable lymphadenopathy. So in a nutshell, we went ahead, did a biopsy. What was the final diagnosis in this case? It was undifferentiated malignancy in keeping with invasive ductal carcinoma metastases. So now you have a normal mammogram and an axillary lymph node, which is giving you a suspicious metastatic appearance. So naturally, you have to go ahead and do a breast MRI because you did not see anything on the mammogram. You're missing a cancer somewhere. So these are the some static images of the mammogram, so of the breast MR. So the image in the middle is a sagittal reconstructed image of maximum intensity projection post contrast. So all you see are these massive lymph nodes in the left axilla. There are multiple of them. I can count 1, 2, 3, 4, 5, 6, maybe even 7. Those are all suspicious, and one of those was biopsied. And in this axial image of the breast, all you see is that there is non-mass enhancement in the retroareolar region as well as within the left central breast. These are in keeping with breast primary. These were biopsied and turned out to be IDC with DCI's component, which was metastasizing to the breast. One interesting thing to talk about in this case, if you pay close attention, the overall burden of disease is not that large. But if you look at the axillary lymph nodes, they are massive. So there's a little bit of disproportion happening here. So no BI RADS by Rania Anand. So I'm not sure if you are still going back to the previous axillary ultrasound image there, but I agree with you. There is no BI RADS category for axilla. But in this case, now once we complete our entire thing, this is highly suspicious for malignancy. So coming back to what point we were discussing here, the burden of axillary metastases is quite high as compared to what is happening in the breast. Especially if you look at this tiny retroareolar enhancement, it is pretty large. The reason why this happens is because there is an increased propensity of ipsilateral axillary lymphadenopathy if the breast carcinoma is present close to the nipple or involving the nipple areola complex. So if anyone who knows about this, they may correlate to that based on their anatomy knowledge. But for those of you who are not aware of this finding, is that the nipple areola complex is richly supplied by lymphatics. It is called as Sapi's plexus. So it is all around the nipple areola complex, and that drains into the ipsilateral axilla. So even a tiny carcinoma at the nipple or close to nipple areola complex can have massive axillary lymphadenopathy. So if you see a small cancer in that region of the nipple areola complex, make sure that you screen the axilla just to be sure that there are no incidental lymph nodes sitting there. The dictum based on the Z11 trial is basically we don't chase the axilla unless the patient has palpable lymphadenopathy if the cancer are smaller than 2 centimeters in size. But nonetheless, in these instances, this is probably one of the exceptions. So coming back to one important slide before we conclude. So remember, the teaching point in this case is role of MRI in detecting MRI occult breast malignancy in cases with symptomatic axillary lymphadenopathy. Always offer this test if you don't see anything on mammogram, but the axilla shows suspicious nodes which turn out to be malignant. Offer breast MRI. So before we conclude today's session, there is this slide which I had prepared for some of the previous talks, but something which is really, really important. So what are the different indications where you will be performing breast imaging? Obviously, screening, if you have screening program available, you can offer mammography as a screening tool. If it is symptomatic, then what are the symptoms you have to look at, or what are the symptoms which patient will commonly present to you as? Patients may have pain. Remember, in pain, cyclical diffuse pain is common in premenopausal women. Ask that patient if the pain is unilateral, focal to some region, and if it persists over 2 cycles. Then lump, obviously, yes, you have to offer imaging. If there is asymmetry on mammogram, if there is nodularity in terms of clinical assessment, if the patient feels that the breasts are asymmetric, then if there is nipple discharge. Now, in terms of nipple discharge, there could be physiological as well as pathological discharges. Physiological are usually bilateral, milky or clear discharge. Then you can also have axillary swelling, as we saw in the last case, and the patients can also present with skin changes. For those of you who have seen advanced malignancies, they can have something called as pure orange appearance, which is nothing but skin puckering due to tense lymphatics and complete lymphatic blockage. So just some other common findings which you can come across in your practice. Obviously, you have seen these simple breast cysts. Again, you may need to aspirate them out if needed, but most of the times these don't need any imaging follow-up. They are BI-RADS 2. Then other benign finding which you can find in certain cases, but it is something which is symptomatic, especially in patient who is coming up with unilateral bloody nipple discharge, are these tiny retroareolar intraductal masses. So if you see, this is nothing but the indentation of the nipple here, and these are two small intraductal masses annotated as A and B, which are nothing but tiny intraductal lesions, which eventually turned out to be papillomas, causing blood in the nipple discharge. So this was all about today's session. So just for reference, I'm just going to bring up this slide and keep it here, and then look at the chat section to see if there's any questions. So Zelda has a question that in her training, limited mammograms, bilateral MLOs are performed in patients under 30 years old. If there is suspicious US finding, what are your thoughts about that? So Zelda, that is a very good thing which you brought up for discussion here. So again, it is really, really important to understand that there is no contraindication to offering mammograms if you are suspicious of breast findings. If the breast findings are not suspicious, patient under 30 years of age, you feel confident on your ultrasound assessment that this is BI-RADS 3 or BI-RADS 2 lesion, you can proceed with imaging finding. You can either do a follow-up in 3, 6 months, 12 months, or 24 months to complete your assessment and downgrade that to BI-RADS 2. If you still feel that it is something which needs biopsy, you may still biopsy that before doing your mammograms and always wait for the histopathology. But if it definitely looks like a BI-RADS 4B, 4C, or 5 lesion, you can always offer a mammogram in these patients. The challenge will be there will be a lot of mammographic density which precludes you from picking up additional foci of disease. But what it helps with is to make sure that you look at calcifications, which will be associated with DCIS. So that's the whole point of offering mammograms. So in under 30 years old, if you are satisfied with your ultrasound findings, there is no need to add a mammogram. If you're not satisfied with your diagnostic breast ultrasound findings, you are suspicious for a malignancy, you can always add a mammogram to complete your assessment. I hope I'm clear about that. So we have also had these situations when, especially the trickiest situation is pregnancy-associated breast cancer. And once in a while, we just stick to an MLO view, at least an MLO view, because that gives you the largest area in the breast to look at. So we have done that in the past. And again, as I said, like, it is at the discretion of the radiologist or the physician who is offering the test to decide what is the appropriate test for that patient. But the radiation risk is very, very low at this point, as you are thinking about something which is going to change the patient's management, because you're thinking probably that is it a cancer? So in that sense, it does not make any sense to withhold that imaging test. So I hope I am clear. So without any further ado, I'm going to close the PowerPoint slides here. So again, thank you all of you for joining our today's session. I'm really sorry about the initial part where we had some technical glitches. Hopefully we will figure something out in the future. I will be able to do some quiz or polling sessions for you. And if you need to see more of such poll or quiz sessions from the past, go and check out our YouTube channel. Amar has done some really good quizzes in the past, which is really nice for the trainees. It always brings more active participation, and that stimulates more thinking. This is the platform to ask your questions, so don't worry. If you have any questions, you can always direct them to us. And remember, these sessions are for education purposes only. If you have any questions, please feel free to reach out to us. So without any further ado, let's close the session. Thank you for joining, and see you on next Saturday.